All right, hello everyone, and thanks for joining us. For those of you who don't know me, my name is Tiffany Scarcelli, and I'm the Knowledge Translation Lead for EpLink. So today we're really excited to get a very important conversation going about mortality in epilepsy. One thing I want to start off with before we start off with the presentations is just to let everyone know that because we feel like this is such an important topic, we're actually going to record the meeting. So if there's any issues with that, please let me know. But it is being recorded. Okay. So the first speaker today probably doesn't need an introduction, but I will anyway. So he's Dr. Burnham. He's the co-director of EpLink, which is the Epilepsy Research Program of the Ontario Brain Institute, and he's also Professor Emeritus of Pharmacology at the University of Toronto.
Okay.
Other keyboard.
The keyboard. Okay. All right. This whole forum stemmed from a talk that I gave about a month ago. And that was based on an article by my co-director, Jorge Burnham. It was a big epidemiological study, and I was quite shocked by it. Simply say that Jorge had been studying about 10,000 patients based on data available in the big databases in Ontario. And he was interested in people who had intractable epilepsy, and he followed them for about 2 years after they had been declared intractable according to the ILAE guidelines. He was really interested in how many of them had had surgery within the 2 years after they were declared intractable, and the answer is slightly over 1%. But the thing that I think was not expected from this is within 2 years, about 12% of them were dead at this point. Now, this has got to raise the question of whether they had had surgery or whether they had been gotten to a really good epilepsy center. Is it possible they would not have been dead? A question really is, how prevalent is excess mortality in epilepsy, and how could we reduce it or prevent it? And that's really what we're going to do today. The keyboard. Okay. Excess mortality or premature mortality are just epidemiological terms for people dying more than expected. They're people dying more than they should be dying in their age group, or people who are dying earlier than you would expect it. It's often referred to as a standardized mortality rate, and I think Elizabeth will be giving you some of those later today. Interesting thing now that I found out when I was first reading up the subject is that people often die shortly after diagnosis. That their most logical time of death, the most probable time of death is within a few years after their initial diagnosis, and often it's within the first year. So just after diagnosis seems to be a very, very dangerous time for people with epilepsy. Elizabeth is going to elaborate on this, but in some cases people die due to an underlying cause. If you have brain tumor or brain cancer, that's the cancer that kills you, not the epilepsy. But in other cases, the deaths seem to be due truly to epilepsy, and in many cases we're seeing to SUDEP, which is Elizabeth's particular specialty, and she'll be talking to you a little about. And these deaths ought to be preventable if we could get the seizures under control, if we could get the people really good therapy. So we've asked Elizabeth to talk about mortality and particularly SUDEP, and Tiffany is going to introduce Elizabeth. This is a very elaborate proceeding.
All right, so our next speaker is Dr. Elizabeth Donner. She is the director of the Comprehensive Epilepsy Program, and she's also a pediatric neurologist at SickKids Hospital. She's also an associate professor in the Faculty of Medicine at the University of Toronto. So today she'll be talking about SUDEP, which is sudden unexpected death in epilepsy, facts and figures.
Thanks, Tiffany. Thanks, Matt. I Yeah, I need my glasses, sorry. Mac asked me to talk for 5 to 10 minutes about, just to kind of give like a bit of a update on kind of the facts and figures. That's why I called it that. So just, what do we know about the increased risk of mortality in people with epilepsy? And what we know is that people with epilepsy have an increased risk of mortality compared to the general population. A standardized mortality ratio means how many times more likely are they to die prematurely compared to the general population. And the standardized mortality ratio for epilepsy is 2.3. So they're 2.3 times more likely to die. If you look at people with chronic epilepsy for several years, that risk even goes up. So the statistic that Mac, or the fact that Mac mentioned that there's a higher rate of death in the early time after diagnosis, I think you have to look at cause of death. So those deaths are due to what caused the epilepsy. So for example, if like a neurodegenerative disease in a child, and it's bad enough that they're seizing and then they die from that, or a new diagnosis of a tumor or something like that. And then the deaths we see later are from a variety of causes, and we'll talk a little bit about that. The standardized mortality ratio in children is even higher. So children with epilepsy are much more likely to die than children without epilepsy. That, first of all, reflects the fact that children it reflects the fact that children don't die very often, thank goodness for that. And so any death that we see in a child is a kind of an outlier and quite a tragedy. But it also reflects the amount of comorbidities we see in children with epilepsy. They have, with significant neurological impairment, you see sequelae, mortality sequelae. I'm kind of blocking, so I'm going to get back and forth. So a nice study was done by Maddie Slappa and Shlomo Shinar. They followed a cohort for more than 40 years, actually. So they enrolled 245 children who were diagnosed with epilepsy in childhood, and they followed them for 40 years. And they looked at a lot of things. One of them in this paper is the mortality. These are not deaths that occurred during childhood. These are deaths that occurred over the 40-year period. So the majority of these deaths actually occurred during adulthood. But they found a 24% mortality in their cohort, 3 times that of the general population. And the risk factors for mortality in that group, the strongest risk factors were active epilepsy, defined as failure to achieve 5-year seizure remission, so not having been seizure-free for 5 years, regardless of medication status, and having symptomatic epilepsy being when there's a known cause, an underlying cause that we can identify, something like a structural lesion or a known condition. Other risk factors that they identified, that have been identified in other cohorts for mortality in general, include difficulties with treatment adherence, so not taking your anticonvulsants as prescribed, and drug resistance. And so the drug resistance is the group that Jorge just recently reported on, right? So as Mac mentioned, we know when a person with epilepsy dies, it could be completely unrelated to their epilepsy, could be, as we talked about, related to the underlying cause of the epilepsy, or it could be due to, quote, epilepsy itself. In these cases, we consider things like consequence of a seizure, so trauma, drowning, status epilepticus, or death due to SUDEP, which is sudden unexpected death in epilepsy. I wrote unexplained/unexpected because the terms are really used interchangeably. The preferred term is unexpected because if a sudden unexpected death occurs, they're generally unexplained, but sometimes in some cases we get to some explanation. We still kind of want to group them together so we can learn from them, so we prefer the term sudden unexpected. Sudden death is 24 times more likely in people with epilepsy than people without epilepsy. Sudden death is what we're going to talk a little bit more about. I'm in pediatrics, so I am interested in kids, and actually Ann Berg and Elaine Worrell and others did a nice study where they combined 4 pediatric cohorts of newly diagnosed children, and they followed them for a total of more than 30,000 years when you consider each year a kid is followed as one. And they looked at how kids with epilepsy died. And what they discovered, which I've already alluded to, is that most deaths in children with epilepsy are not epilepsy-related. Okay, so this is their series there on the left, and then Ackers and Harvey, two other pediatric series. And you see the yellow bars represent the percentage of non-epilepsy-related deaths, and by far children die much more frequently of non-epilepsy-related deaths. And just to dig into this a little bit more, and these are Elaine World slides, so I thank her for those. You can see that the most common cause of death in children with epilepsy is pneumonia. So that's because we're talking about kids with severe neurological impairments in association with their epilepsy, and kids like that are very susceptible to respiratory infections. The kind of runner-ups are a variety. They kind of have to group it. So in the purple bars, like a variety of other natural causes, things like sepsis or renal failure, like just different medical causes that cause death. But respiratory illness is the highest cause of death in children with epilepsy. But if you do look at the, did not move forward, right? Oh, no, sorry, so pneumonia, right. And then if you do look at the epilepsy-related causes of death in children with epilepsy, so take the pneumonias out and the non-epilepsy-related causes, SUDEP is by far the most common cause of epilepsy-related death. So in Anne and Elaine's study, more than 70% of the epilepsy-related deaths were due to SUDEP, with small little bits of deaths related to status or aspiration during a seizure, so choking during a seizure. That's pretty consistent in the other studies as well. So just to define SUDEP for a moment for people who are less familiar with it, it's the sudden death of a person with epilepsy. They need to have epilepsy. We define that as recurrent unprovoked seizures. That excludes kids with febrile seizures or people with withdrawal seizures from alcohol or seizures related to diabetes, because those would be provoked. The death needs to have occurred unexpectedly when they were in a good state of health, and the death needs to have occurred suddenly. Some of these deaths are witnessed, but the majority are not. Probably around 15%, 10 to 15% of SUDEP deaths are witnessed in adults. The rates are higher in kids, up to 50 or more percent in kids are witnessed. You don't have to have a seizure before SUDEP death. And for those of you that are familiar with the literature, there's a growing body of literature reporting deaths that have occurred in epilepsy monitoring units. All the deaths that have occurred, all the SUDEPs that have occurred in epilepsy monitoring units, the person who died had a seizure immediately before they died. I do need to highlight the fact, and I think that work comes from Philippe Roulin and others, and I think he would agree, that that's a certain specific cohort, right? Because those people were in the epilepsy monitoring unit having had their drugs withdrawn, so to encourage seizures. So that is a specific cohort. So certainly it's more common to have a seizure before, but I know of quite a few cases where there was not a seizure before death, or at least not a seizure that we could see. It's possible, of course, they have some clinical seizure, but not a convulsive seizure that we could see. And we get more information about that in pediatrics because more pediatric cases are witnessed, because for those of us that work in pediatrics, you know that it's really hard for parents to leave their children with epilepsy alone, so they're often with someone. Other stuff here to talk about, just when we talk about what is a SUDEP death, is that the autopsy, to meet full criteria for SUDEP, an autopsy needs to be performed, and it needs to demonstrate no cause of death, anatomic or toxicologic cause of death. The challenge is that many cases don't come to autopsy, so for the purposes of research, we have some other categories. We have possible SUDEP and probable SUDEP. In cases where it appears that the case is most consistent with SUDEP, but we can't make that final kind of diagnosis because there was no autopsy available. How common is SUDEP? Well, the easy to remember number is 1 per 1,000 patient years. So that means if 1,000 people are living with epilepsy for 1 year, and one of them will die over that 1 year of SUDEP, and have to replace that person, wait another year, one person will die. It's almost 10 times higher in people with drug-resistant epilepsy. Those are studies of people getting a vagal nerve stimulator or people being worked up for surgery, so up to 9 per 1,000 patient years. And I think I have a little typo. The lower risk in children, there should be a little dot. It should be 0.2 per 1,000 patient years, or 2 per 10,000. So it's like 10 times higher in refractory epilepsy, and it's about 10 times lower in children. What do we kind of what have we observed when we studied these deaths from a variety of papers? The deaths most often occur in a prone position. People are usually found dead in bed in the morning, prone. I mentioned that about 10% are witnessed, and that there's evidence of a convulsive seizure in up to 90% of the cases. So that's nocturnal stuff in a moment. I'm conscious of not taking too much time. Dale Hestorfer and her colleagues, as part of the ALE Commission on Mortality, had a look at risk factors for SUDEP, and this is kind of the best paper that did that. What they did is they combined a few cohorts to get a total of 289 cases of definite or probable SUDEP, and they compared it to over 900 liver control. They stratified the cases by age of epilepsy onset because it's quite clear that childhood onset epilepsy increases risk. So we wanted to look at people who started with their seizures under the age of 16 and over the age of 16. And by far, the most robust risk factor for SUDEP is recurrent generalized tonic-clonic seizures. The problem is that most of us who treat people with drug-resistant epilepsy think that recurrent or frequent tonic-clonic seizures is like 1 a week. But actually, the risk of SUDEP goes up with like 3 in a year. So what some of us might consider frequent is actually a tremendous risk for SUDEP. I think we put some numbers there. So they included polytherapy in this analysis, but I'll address that in a moment. But having more than 3 per year in people with childhood onset epilepsy raised the risk of SUDEP 37 times. And that's just 3. And so many of us know so many people who have them. Polytherapy issue is really important. I'll just address that quickly. At first, they thought that polytherapy, meaning being treated with multiple drugs for epilepsy, taking multiple drugs at one time, was a risk factor for SUDEP, but they had failed to control for the number of seizures. And so once you consider the number of seizures, and obviously people who are taking lots of drugs are having more seizures, that's why they need the lots of drugs. Once they pulled that out, it was no longer a risk factor. That's really important. It's really important for our patients not to think that the drugs are what's doing it. In fact, they've done really nice analyses a few different ways now, and it doesn't appear that any single medication or the number of medications that a person takes changes their risk or increases their risk. There's even a suggestion that that adding on new therapy can reduce risk. And so this is a study where Philippe Rivlin looked at the randomized controlled trials that our industry partners do, and as everyone knows, they need to maintain very meticulous data around mortality in industry trials. So they put together a whole bunch of randomized controlled trials, 112, and within 112 randomized controlled trials, they found 33 deaths, 18 of them were SUDEP. What they found that within those populations, the people who were receiving an efficacious dose of the drug, the study drug, had a 0.9 per 1,000 person-year risk, and the people who got the placebo had basically a 7 per 1,000 person-year risk. So some people have been upset by this, thinking that it means that if we don't, that we're making SUDEP higher by putting people in a randomized controlled trial and allocating them to a placebo. It's probably true. It's a bit problematic. Max kind of smiling and nodding, but it's probably the proper way to look at it is that actually, given that these were people with refractory epilepsy being enrolled in drug trials, this is probably their baseline risk. So they probably have a risk near what we've seen in other populations, like those for VNS and those being worked up for surgery. So they probably have around a baseline risk of about 7 per 1,000 person years. And getting an efficacious dose of a new drug brought their risk down. Other risk factors, and I'm happy to talk on and on, but I won't because I know we don't have a lot of time, but other risk factors that have been identified include the presence of nocturnal seizures, longer duration of epilepsy, and those are important ones because those are potentially modifiable risk factors as opposed to things like male gender, learning disability, and what age you are. We can't do a lot about that. And that's just to demonstrate duration of epilepsy. So I'm just going to sum up so that we can keep moving forward and highlight for you who we know is most at risk of SUDEP. That would be adults, and it looks like the age of highest risk is between 20 and 40 years of age. I think that that's inaccurate given that now that I do a lot of work with coroners and pathologists that come to understand that it's almost impossible to have an unexplained death over the age of 40. They can always find something that has done offense, sorry. So it's very hard to be signed out as a kind of like a normal autopsy after the age of 40, so I think it's kind of biased. But adults with early onset epilepsy and refractory generalized tonic-clonic seizures are the highest at risk. So we need to remember that seizure reduction, particularly generalized tonic-clonic seizure reduction, is our most important treatment goal. We also need to remember that that's not just to keep a driver's license or not be embarrassed by having a seizure or not break a bone, but it's actually to try and save lives. And I'll stop there.
Thank you, Elizabeth.
You're welcome.
So our next speaker is Mr. Drew Woodley. He's going to speak today about perspectives and experiences of mortality and epilepsy from a community epilepsy agency such as Epilepsy Toronto.
Good afternoon. As Tiffany said, my name is Drew Woodley. I'm the Director of Communications at Epilepsy.
And
There we go. At Epilepsy Toronto. For those of you who don't know our agency, we are a community service agency that provides counseling, support, advocacy, and education to Toronto's epilepsy community. Primarily, our direct service staff are social workers who do everything from counseling, both for adult, family, and children, to employment counseling, as well as community education and trying to reduce the stigma associated with epilepsy. Over the past week or so, I've had the opportunity to discuss the topic of mortality with Epilepsy Toronto direct service staff, and I believe their anecdotal experiences, both from clients and from their own experiences, is useful in helping to frame this discussion. I'm not coming with statistics; these are very much anecdotal experiences from our staff. As a community agency, Epilepsy Toronto faces no shortage of tensions and contradictions when it comes to discussing the possibility of death with our clients. I'll give you a quote. This is from Anna, whose son died from SUDEP at age 19. I never heard that he could die from epilepsy, how serious it was. I was worried about the medication or if he was going to be slowed down. Maybe the doctors don't want to scare people, but I think it's good for the family to know that there is death from epilepsy. We'll be prepared for it. Why do we talk about death as a community agency? There are a number of reasons why it's become part of our client counseling and education program. First, our experience is that the discussion isn't happening with many physicians. Our counseling staff report that most new clients, even newly diagnosed clients, haven't discussed the possibility of dying from epilepsy, whether from SUDEP or status or through injury, with their medical professionals. Second, a core part of our organization's mandate is to help people living with epilepsy to live well. That means helping them to live as independently as possible, as defined by our mission, vision, value statement. But with that comes an ethical obligation to help them do so safely, and by extension, educate them about why self-care and risk minimization are necessary. Not talking about death is a risk in and itself. Third, even where the risks of death are statistically low, or the client or their family has a good care plan, the discussion is necessary. Prevention and preparation aren't the same thing. Anna came to our agency after her son died, and she regrets not knowing, so she could have at least prepared herself mentally and emotionally for the possibility. A parent diagnosed later in life may well want to ensure that their affairs are in order, even if the possibility of death is remote. So why are we reluctant to do so? None of our counseling staff consider death an easy topic to discuss with our clients. Each and every counselor I spoke to found talking about the subject with clients made them anxious. They identified not wanting to make the client uncomfortable or scare them unnecessarily as the primary reasons, so whether risk factors are low or whether there's little that can be done to lower that risk. They acknowledge that, with rare exception, the client's discomfort with the subject seems to actually be less than their own, and that the client understands why it's important to know. But interestingly, the counselors reported clients who knew about the possibility of death subsequently not telling their loved ones, because they didn't want to make their family members uncomfortable or scare them unnecessarily. So seemingly knowing about the possibility of death is seen as a burden that ought not to be shared. Further, counselors are cautious of broadcasting it or approaching it with clients who think that they might fixate on the possibility. This is especially true when talking to parents of young children with epilepsy. Yet we do talk about it. And we do raise the possibility of death. Perhaps not always evenly and perhaps not enough, but more than even in the recent past. Organizations like Student Aware and Dr. Donner's work and other researchers' work have forced us to make it a priority to not shy away from the topic. And our counseling staff therefore take an individualized approach to discussing it with clients. Newly diagnosed clients will receive a mention of it during an Epilepsy 101 session with a counselor. It's identified but not focused on. Clients in higher risk categories get a deeper discussion and significant consideration is put into timing and developing a rapport with clients so that sensitivities of the topic can be approached appropriately. We know we can do better at this, but we need your help to do so. First, we need researchers and statisticians to help us explain the numbers to us so that we can explain it to our clients. The majority of clients we see have intractable epilepsy. So to use Dr. Burnham's study as an example, we don't see 12% of those clients dying every 2 years. That number seems alarming and counterintuitive to our experience, so we need the help of the medical and research community to understand that statistic well enough that we can understand it ourselves and communicate it to our clients. I took stats about 15 years ago. You need to explain it to me to a point where I can explain it to someone who has no statistics background and make that conversation meaningful. And we need your help through meetings like this to get a better grasp on the situation so we can provide that accurate information to our clients and communicate it to them in a way that is correct and that they can comprehend. We also need research that focuses or has a component on prevention. And that's very meaningful for us. Clients often ask, now that we know, what can we do? As I mentioned earlier, one of our organization's goals is to help people with epilepsy to live independently. But that's hard when with clients whose risk factors mean they sleep in the same room as their parents into their teenage years. That's a way to reduce the risk of suicide. That kind of work that builds on existing prevention techniques and technology available can have a meaningful impact on the lives of our clients and provide our agency a better way and a more effective way to communicate what is a very sensitive topic with them. Okay, thank you.
Let me simply say, the question is then, what's going on? It looks like we do have excess mortality in epilepsy. It looks like SUDEP contributes a lot to this. And from Hero's talk, it looks like in certain patients, you can probably predict the possibility of SUDEP from their EEGs if you have an EEG. Now, in EpLink, the question is, what can we do about this? Point of our program is to improve clinical care for people with epilepsy. I think we've all thought of seizure control as a question of quality of life, but it looks like seizure control can be quality of life or death at this point. So what can we do to predict, or shall we just say, what could we do to decrease the deaths in people with epilepsy at this point? And I'm going to try to get input from you guys at this point. One question is, if in fact people often die early in the course of epilepsy, which may be because of the underlying cause, but if we could get people to a specialist or a specialist program sooner, would that decrease the likelihood of death in epilepsy? Maybe I'll ask Elizabeth to shoot off.
Sorry, just a quick comment is if there is discussion, just make sure that you're speaking loud enough so that people on the phone can also hear.
Won't be able to see you then, right? I think the thing is that I don't think that the argument for early referral of a specialist, early referral to a specialist should be made in an effort to decrease the early deaths, because I'm not sure that that is the outcome there, because I think the early deaths are related to things that are untreatable. I think if they were treatable, hopefully people wouldn't die. Although early deaths after diagnosis of refractory is different than early that's after diagnosis of epilepsy because it takes some time to become refractory. I think the argument for early referral and reduction in SUDEP is related, or mortality in general, is related to earlier treatment to epilepsy, having a less lifetime burden of generalized tonic-clonic seizures will reduce the number of people with refractory epilepsy, reduce the frequency of generalized tonic-clonic seizures, and reduce mortality.
You've given us a figure for refractory epilepsy of essentially one death per 100 in a year.
Yeah.
And this is
9 per 1,000, pretty close, yeah.
This is maybe the figure the Epilepsy Association needs to hear. We hear 1 in 1,000 a lot, but that includes a lot of people with well-controlled epilepsy. When you go to people with uncontrolled seizures, it's 1 per 100 per year at this point. The question is what to do. If someone's refractory, if they're being treated basically by a GP, will he even recognize or she recognize what's going on?
Well, but the new Ontario strategy is profoundly clear that anybody with a drug-resistant epilepsy, I don't know how they decided to define it in the end, 2 or more drugs probably, should be referred to an epilepsy specialist, not even just a neurologist. I mean, so one step from GP, next step to neurologist, and then to epilepsy specialist. I mean, so it's very clear that people with drug-resistant or refractory epilepsy should be referred to an epilepsy center, at least for a one-off consultation to see whether they're a surgical candidate and what else can be done.
Okay, try 2 drugs, they don't work, you're still seizing, you should go to Dr. Wang or to SickKids, but does that happen?
Or Dr. Reed? No, absolutely not. I mean, there's a complete failure of the system there.
And that's where we really break down. People with intractable epilepsy do not get referred for the help they want. How could we change that?
Education. Aileen, what do you think? Aileen's an adult neurologist.
I think that is one of the biggest issues is that, their GP or sometimes even a neurologist doesn't necessarily have the same view as we do on what is controlled epilepsy. And I don't know how many letters, like, well, the patient, is only having 1 GTC a month or something. And I think to some of them, maybe if it's an improvement from some time in the past, then they think that's better. Or even, and so the patients themselves come to me and they have the idea from their doctors before them that their epilepsy is well controlled, especially I think if they have focal dyscognitive seizures and not GTCs. They're like, oh, I only have like 1 a week, it's not that big a deal. And I mean, to me, that is way too big. So a lot of it is education, or if they think the MRI is non-lesional, they don't think there's anything we can do. And so, they may not think the patient is a surgical candidate and doesn't need to be referred because there's nothing we'll be able to add.
But one way to improve the education is not just by educating doctors. I mean, we have to do that, and I think there's certainly a lot of efforts to do that, but by actually educating patients. I mean, patients come and they say, Dr. Donner, you've been trying your best, it's not working out, I want to see someone else. And I'm thrilled, right? Like, that's great. You need to think that you've done everything you can to help your kid. And people need to go to their doctor. People with epilepsy need to go to their doctor and say, like, doctors need to recognize it, but we're trying that, but people with epilepsy need to go to their doctor and say, I think I need to see a specialist. So that's another avenue of education.
Sure, that's why you're here.
Absolutely.
We're going to try to educate GPs, but I think GPs in general do refer cases of epilepsy. Neurologists, non-epileptologist neurologists often don't. And until I heard Elizabeth, I thought 3 tonic-clonic sign, that wasn't too bad. Your risk is way up, or with Hero, 5th or 6th tonic-clonic can kill you. I don't think people understand that.
Actually, you did in a survey with the pediatric.
Of general pediatricians, we surveyed pediatricians through the Canadian Pediatric Society, and the vast majority of pediatricians didn't even know that kids, forget knowing terms and words, but didn't know that kids with epilepsy were at risk of sudden death.
And I think for the vast majority of patients, and maybe neurologists reinforce this, if you're going from a seizure a day, or multiple seizures a day, to 1 a month, that is such a vast improvement in quality of life for a lot of people that they see that as an endpoint. That, yes, my seizures controlled. And I think part of our discussion, our education needs to be, there's a step beyond control, and we should look at elimination as well.
It's hard to talk to people with seizures about death, but it might make a big difference if we would, and if they would not say, okay, I'm only having 3 a year, that's okay, because it's not. If we did, what Elizabeth is saying is early referral, not a big thing, because a lot of the early death is not pseudo.
No, I'm saying early referral, you can't make the argument that that's going to reduce early death. I think it's going to reduce the development of drug-resistant refractory epilepsy, because we're going to take lesions out faster, we're going to get seizures controlled faster, and there's going to be less kind of worsening of the epilepsy.
But going back to Jorge's study, it's when you're in refractory.
Once you're refractory, yeah.
Then early referral becomes, I think, crucial.
Theoretically, once you're refractory, you should be referred right away. Like the same appointment where the doctor says this is drug-resistant epilepsy should be a referral to an epilepsy center.
I guess the question is, could the specialist centers or could the specialist doctors like Dr. Wang handle this?
I'd like to play the devil's advocate. Because we don't know the mechanism of sudden death in epilepsy, we don't have a way of primary prevention. So what we talk about is early diagnosis or secondary prevention, such as monitoring or refractory epilepsy. I think we're just covering our own behinds by referring to a specialist. Oh, I discharged my responsibility, see XYZ at SickKids at Toronto Western. We're not really doing any service. I've lost 4 patients in 25 years of practice with over 10,000 patients. We have presented any of this. I doubt it.
Well, I don't think you need to focus on, I don't think you need to focus on mortality reduction or preventing SUDEP to justify referral of people with refractory epilepsy to centers where they could be evaluated for surgery. We know that surgical referrals are profoundly low compared to people who are potentially available for surgery. So I think we need to encourage referral to make sure we're not missing surgical opportunities. The numbers alone suggest that Toronto Western is seeing way too few, it's not your fault, but way too few people through their EMU. And they do have increased capacity thanks to the recent Ontario strategy and investments by the Ministry of Health. So I think you guys should see more.
Jorge Bunio tells me that 12% of his patients die before they come to epilepsy.
Yeah.
I think he's looking at a very, very highly select subpopulation. That is, they've been gathering these patients, their waiting list is 2 years long to get EMU and another year to get the surgery.
Well, Paul, what I point out to you is the people at CU have got referral to
That's
the
the thing.
specialist.
Yeah, he has
You stop their seizures. This is
I
a
have no
population we're
active
looking at.
grind. I use the same medications that ever.
But not the same medications that they might get if they went to someone specialized in Parkinson's disease, for instance.
I think before we put the burden of morbidity on the backs of children and their parents and say, you have epilepsy, there's 1 in 1,000 chance that your child may die. What happens is, of course, mother will never let the kid out of her sight. Father will be left out in the boonies, and sooner or later the family will break up.
So there's no evidence for that, though. So there's been qualitative and quantitative, I guess you would call them, studies that have looked at the effect of SUDEP disclosure on families. Rajesh, our colleague in Hamilton, did focus group studies, qualitative studies, where all the parents said they wanted to know, whether they were bereaved parents or parents who were taking care of a child with epilepsy. And there's a study by Susan Duncan where she they gave it was part of their practice to give SUDEP education, and then they did a study where they asked them how it changed their management and whether people took better care of themselves and stuff like that. The alarming thing is people didn't take better care of themselves after they learned about SUDEP, actually suggesting maybe her messaging wasn't good enough, or we don't message it right, not her specifically, but we're not messaging it properly. So You know, and there was another study with the kids. Well, there was another study that looked at whether parents were more protective of their children after they learned to suit up, and they found that they weren't.
If one takes the practical approach and say you require at least 5 minutes counseling for every patient with epilepsy, for a cohort of 4,000 plus patients times 5 minutes, that's 20,000 minutes divided by 6, 3,300 hours that we do not have.
This is the question really of who should be
You bill
addressing this.
OHIP, you got $68.50 every 6 months. And where are you going to find 3,300 hours? You can do it in an academic center with your paid salary, your nurses, your counselors, your psychologists. Out in the real world, it's not practical. You have to be highly selective, candidates at risk, 2 or more convulsions, 5 or more seizures, not 6. Okay. And then you provide counseling to the ones at
So
risk.
we can look at models where we share how we communicate with families, right, and whether community agencies are willing to assist with that.
Yeah,
And
maybe it's the community agencies that might pick up the slack here, because doctors do have limited time.
I mean, they asked patients that too. They asked parents that too, and they heard they wanted to hear it from their doctor. So just so you know, that's what families say. But certainly partnering, to me, does make sense.
And I think there's a continuity between informing patients and supporting them and counseling them through
Yeah.
community agencies.
Yeah, great point. So hearing about it from Paul and then coming to you to talk about how upsetting it
No,
was.
I agree with what Bernard said. We heard it all at the last workshop.
Yeah, this was quite a topic at our last workshop.
It was.
So maybe that's an important discussion that we're having is what would be the best approaches to talk about mortality in epilepsy, to talk about sudden unexpected death in epilepsy. Yes, there's limited time in a neurologist's office, but you know, community epilepsy agencies do play a large role, but also have some limited resources as well. So it's good to understand, like, to talk about maybe what the best approach is to informing people.
Nancy, maybe could I put you
Tongue in cheek, of course.
on the spot? Dr. Mingo is a general practitioner. Is this something that the general practitioners could conceivably do when they have patients?
I think so. I mean, there's an obvious parallel to early pregnancy. You don't, we used to say, oh, never bring up the subject of miscarriage. It's so upsetting. And there's nothing they can do about it. But uniformly, patients say that telling them you're pregnant, and by the way, there's a perhaps 1 in 4, 1 in 3 chance that the pregnancy may end through no fault of your own was terribly reassuring for in the unfortunate case where it did end. And, that was an extra 6 or 7 words. It didn't add a lot to the counseling. So maybe something that could be just brought up and not fully addressed, but
But one thing that an epilepsy center can offer is, of course, surgery. Diet too, but surgery is probably the underused one. One question, though, is are patients ready for surgery? To what extent is the patient's fear of surgery part of the problem? And Drew, I don't know, do you have a feeling?
I wish Rosie Smith was here, who's our director of Epilepsy Services, because she works very closely with surgery patients, or potential surgery patients. I don't know if that preventing the numbers that we're talking about. I think the referral is the first step, and from there, then you have a more in-depth discussion about pros and cons of surgery and risk. But I think that the larger blockage is the referral.
I think when a lot of patients get to me, they don't necessarily know that surgery is even an option or it's not really something they've thought about. But, I mean, I don't think that's important. We can talk about it then. I don't expect them to be necessarily well educated on surgery by the time they get to me. We can talk about that, try and figure out together whether they may be a candidate and try and discuss, you know, any fears that they about that. But a lot of them don't really know much about surgery, I would say, by the time they get to my office.
Do you think fear is a barrier to people having surgery? Like a significant, like for a significant number? I mean, I agree with Drew. I think the referral problem's much bigger.
I haven't noticed it a lot here. I'm not seeing as many patients, so as I did when I did my fellowship. I mean, I was in UCLA, and there were certain, I think, cultural reasons that people, like particularly the Hispanic population, they very much did not want to have surgery. They were very afraid of surgery, and I mean, I think that's something that's been published, and it was often a barrier when they came. And they would come and do the whole workup, and then we would never see them again. They wouldn't even come for follow-up once we told them surgery might be an option. I haven't found it to be really a problem here. I don't think I've yet had a patient who I thought would benefit from surgery, and we, got to the point where we really could discuss that, and I think that.
I have a friend who, in fact, almost died of status this year. Finally agreed to look at surgery, and was terribly afraid of it, and was greatly afraid of the pain that she thought was associated with surgery. Do you find that can be a barrier?
Pain?
Yeah.
I don't know that anyone's come to me with that, but if they had, I think that's something we could easily address, because that's really not an issue.
This is not a particularly painful type of surgery.
No.
It's interesting. I was shocked because my friend is pretty well educated. Apparently, it was a great barrier. She thought she was going to go through terrible pain as a result of this. Once again, public education.
Yeah.
And where we've had very good success, I can't quantify this, but is through the peer and pre and post surgery groups that we've associated with that discussing the possibility of surgery with someone who's power and provide agencies to.
I don't see any. There's not much public service. There's not many ads about epilepsy these days, are there?
No.
Like you see healthy women running who have breast cancer and stuff like that, right? Wearing pink. Can you imagine a TV ad or something like that where it shows someone who, there's a picture in the corner of them lying in the ICU bed looking horrible after they've had status epilepticus, and then there's a picture of them I had my epilepsy surgery and now I'm healthy. Maybe we need those kind of things.
I mean, even within our community, we're seeing large intractable. 70% who are well controlled.
They don't need to come to you.
They don't need to come to us, right? And I think that's part of it, that the vast majority are controlled, and so it's not something that there isn't a mass movement to get this into the public realm for discussion.
Right.
Maybe we need to, but.
Well, other comments? We've pretty well run our hour, and we do tend to try to stay on time.
There was one other comment online, just a quick thing. Is there an opportunity for a script or some sort of discussion, guidelines on how clinicians and agencies should discuss the topic with families? So we kind of talked a little bit about surgery, or also potentially mortality and epilepsy. Is there an opportunity for that kind of script?
There are videos that we made through the SUDEP Institute, which is part of the Epilepsy Foundation in the U.S. There's some videos we made of examples of talking to people about SUDEP or about mortality risk. So that exists.
If not, we can make them.
I certainly have. I do that when I talk. I have a talk about talking about it. And so I think that there's an opportunity there.
A Canadian one with people with Canadian accents might be a very good idea. Anyway, thanks to everyone for coming out today. I think.
Thank you, Matt. Thank you.